Good afternoon to everyone, and welcome at this webinar titled Aperto DCB, A Glimpse to the Future Today. My name is Diego Squara, and in name of Cardionovo, I would like to thank all of you for the participation, but I would like to thank also the great panels we have today with Dr. Panagiotis Kitru from Patras, who will introduce this webinar, sharing with us the role of the DCB today and tomorrow in the vascular access management, but also Professor Tozzi from Varese, providing us an overview of the latest update of Aperto DCB clinical studies, but also a cost-benefit implications. And last but not least, Robert Chavardian from Hamburg, who will provide us his algorithm for the treatment of the management of the fistula and sharing with us some cases with Aperto. So I would like to immediately introduce Dr. Kitru, who will provide the first presentation. I would like just to inform all the participants that in case you have questions, please use the Q&A panels, and at the end of the sessions, we are going through the speakers to reply to all of them. So enjoy the webinar, and Dr. Kitru.
Good afternoon. Thank you for the kind introduction. Let me share my screen. Okay, the theme of my talk today is going to be about the role of the drug-coated balloons today and tomorrow. So just to clarify, so far regarding the guidelines, the optimal vascular access stenosis treatment is balloon angioplasty and high-pressure balloon angioplasty as needed. Both the KDOQI and the ESVS guidelines do not provide any recommendations regarding drug-coated balloon use in vascular access, and this is mainly due to the fact that both the KDOQI and the ESVS guidelines were published before the big DCB trial. So the KDOQI were published in 2019 and the ESVS guidelines in 2018. What is our main problem? The problem is stenosis in vascular access, a stenosis that we need to repair immediately because the patient needs to go back to dialysis, but unfortunately wrist stenosis will occur, and then we will need to repair this wrist stenosis again. What is responsible for stenosis, and what is the histopathology? So there are three main factors leading to vascular access stenosis. The first one is the vascular access creation itself, which is a dramatic and traumatic event with fibrosis, incisions, sutures, etc. Then the vascular access is cannulated during dialysis with 2 needles 3 times a week in most of the cases for 4 hours. And the other is that the inherent problems of end-stage kidney disease that have caused oxidative stress and hypoxia to the endothelium. So all these factors cause inflammation and endothelial dysfunction that leads to venous neointimal hyperplasia. So this is the key words, venous neointimal hyperplasia. And this hyperplasia is mainly myofibroblasts and differentiated contractile smooth muscle cells that they produce an excessive extracellular matrix. So these cells, together with the matrix, they produce this fibromuscular aggressive thickening of the vascular wall, and this is venous neointimal hyperplasia. So in this frame of stenosis and wrist stenosis, we need two things. The first one is that we need what the cardiologist mentioned as immediate lumen gain. So we need to fix the vessel. We need to fix the flow because the patient needs to go immediately back to dialysis. And the second thing is that we need an adjunctive treatment that will increase the period between stenosis and wrist stenosis. So a few things. Wrist stenosis to occur needs cells that come from the outer vascular layers, neighboring tissues, and circulation. And like we said, they accumulate, they divide, and they produce this extracellular matrix. So if we would have a cytotoxic factor that could attack these cells, it will stop these things, and it will also slow down the process of wrist stenosis. And to that end, and up to date, this cytotoxic factor is paclitaxel. Let's see a few things. How did it all start with paclitaxel in vascular access, drug-coated balloons in vascular access? So the first study came from our department in Patras. It was a randomized controlled trial, drug-coated balloons versus PTA, 40 patients with fistulas and grafts. And at 1 year, the target lesion primary patency was significantly better for drug-coated balloons. The interesting thing is that when we did a subgroup analysis for ABGs and AVFs, we found out that in the subgroup of grafts, this signal was there. There was a significant difference in favor of drug-coated balloons, but this did not happen in fistulas. So we were wondering whether this is because drug-coated balloons are not working in fistulas or the number of cases, 7 in each group, was small. That's why we performed a second randomized controlled trial only for fistulas when we saw that the target lesion revascularization-free survival was significantly better for the drug-coated balloons, but also the access circuit primary patency was significantly better in this case. Where do we stand today? We have a number of studies. We have a vast number of cases. So you can see there are more than 34 studies and more than 1,900 patients in these studies have received a drug-coated balloon treatment. And so far, we have 7 devices. One of them with a high number of cases is the APERTO from CardioNovo. What have we learned from all these studies? What are the important things we learned? So from a global multi-center perspective registry from Dr. Kanapatidis and colleagues, which was 320 patients, endpoint at 6 months. It was an all-comer study, so central veins, grafts, fistulas, everything. What we found out is that it is important that we perform a predilation. So in the cases that no predilation was performed, the results were worse. And the second thing is that when the drug-coated balloon was inflated for more than 120 seconds, means more than 20 minutes, the results were significantly better as well. So another important thing is how we perform predilation and how we make sure that we cover with our drug-coated balloon the predilated area. So you see here initial stenosis there that is that receives vessel preparation with a high pressure balloon, 7/40. You see the results, less than 30% residual stenosis. So then we introduced a drug-coated balloon 7/60. So the high pressure balloon was a 7/40. This is a 7/60. And now I will overlay for you the two images, and the 2 red arrows show where the drug-coated balloon is, and here is where the high pressure balloon is. So you have to make sure that you will cover the vessel preparation treated area with your drug-coated balloon to the full length and an extra half a centimeter on its edge. Another important thing is that when you have, like in this case, you have a stenosis at the cannulation zone, we treated with a high pressure balloon 7/80. So we had to use a longer drug-coated balloon, which was not available at our department at that time. So what we did is we used 2 drug-coated balloons, a 7/40 and a 7/60. So in case you use 2 drug-coated balloons, you have to make sure, and you can see that in this overlay, that you cover the in-between segment enough so there is no geographic miss there as well. And this is the final outcome. Another interesting finding came from another study when we investigated what are the results of consecutive treatments. And what we came up with is that there was a significant difference in favor of a second treatment with a drug-coated balloon. So you can see that the first intervention, the post-intervention primary patency was 269 days, while in the second intervention was 520. So another thing that you can get an augmented result theoretically with the second consecutive treatment. We also have studies on central venous stenosis. There are 7 studies, 200 patients. So we perform, it's a work in progress, a meta-analysis on these studies. Some of them are cohorts from other bigger studies. And what we came up with is that safety was 100%. And the target lesion primary patency at 12 months was 35.61% from all the studies. And I'm talking about central venous stenosis. A very interesting finding came from this study, which was a multi-center one, 86 patients, 17 physicians involved, 11 centers participating across Europe. You can see the target lesion primary patency, the access circuit survival up to 2 years, and the patient survival. They are quite good. The most interesting finding is when we did the Cox regression analysis, we found that the only independent factor that would positively influence the primary outcome measure of target lesion primary patency was the balloon diameter. So an increase by 1 millimeter of balloon diameter improved the target lesion primary patency by 29%. So that's a third very interesting finding. There's also an excellent study from one of my friends and colleagues who is with us in the panel today, Dr. Shaverdian, who was the first who actually tested the drug-coated balloons in percutaneous fistula, which he also showed that that significantly more patients require reintervention with a PTA compared to drug-coated balloon groups in this single-center retrospective analysis. And I'm sure he could give you an insight to this study as well. What about safety? There are 3 studies with 1, 2, and 3 year outcomes that show no mortality signal in all in these studies, and although they were also with different drug-coated balloons. So to summarize, procedural characteristics for drug-coated balloons are very important. So vessel preparation, time of inflation, and balloon diameter. Drug-coated balloons are drug delivery devices. They are not angioplasty devices, so you have to prepare the vessel, you have to do the mechanical work with a high pressure balloon and then use your drug-coated balloon. Repeated interventions with drug-coated balloons may have better results. Drug-coated balloons may have a role in central veins, and they may have significantly better results both in surgical and percutaneous fistulas. They behave, fistulas behave better than grafts, and there is no mortality signal for drug-coated balloons in vascular access. What are the problems? The problems is that not all drug-coated balloons are the same. We have different paclitaxel concentrations, we have different excipients, and not all lesions are the same. So like you wouldn't compare the results in the iliacs or the SFA or the below the knee lesions in PAD. You wouldn't do that with different circuits, with different sites. For example, the cephalic arch, the outflow veins, the central veins. There are different lesions like de novo and restenotic, and there are also different types of lesions like fibrotic or hypoplastic lesions, or although I have an asterisk there because I'm not a really big fan of this differentiation. And last but not least, not all patients are the same. So we have different geographies, and in these geographies, we have different ways of performing dialysis. What does the future hold, and what are the unmet needs in this field? We need more studies. We need, ideally, we would like to have a patient-level data meta-analysis so we can pull all this data together and maybe come up with specific lesion site endpoints. So, or we can have lesion-specific studies, like, for example, the cephalic arch or the venous graft anastomosis, etc. And definitely we need more central venous stenosis studies. The new drugs on drug-coated balloons, which are rapamycin derivatives, the Olimus family, will need a lot of time, minimum 3 or even more years to provide valid data information comparable to the paclitaxel drug-coated balloons. And the new medical device regulation in Europe is a major obstacle for further investigation. So overall, drug-coated balloons are safe and effective in vascular access. A lot of lessons have been learned during this 15-year period, not only regarding drug-coated balloons, but also on how to improve PTA results. So one of the major advancements with drug-coated balloons is that we focused on how to perform proper balloon angioplasty. And as vascular access creation has better results in experienced hands, the same stands for restenosis treatment and drug-coated balloon use. So operators should understand the indication and limitations of drug-coated balloons as for every device. Thank you for your attention.
Thank you, Panos, for this fantastic presentation, also because you underline the strength of the use of DCB in this field, and also the doubt, because today we have some doubts about the indication, the treatment, the type of stenosis, and naturally the type of patients. So thank you, Diego. I share rapidly my screen, and I start with my presentation. You see my screen? Okay. Good afternoon. Thank you to everyone. I continue the fantastic presentation by Panos with the clinical and cost efficacy analysis. So today we have a very evidence-based approach when we perform an AV fistula or a graft, when we decide to start an hemodialysis with a CVC. But we don't have an idea or really a plan for the maintenance of our vascular access, and this is mandatory, because without a correct follow-up, a correct maintenance, all type of vascular access thrombosed, and the failure is the end of the history. So today, probably in the virtuous circle of the treatment and performing the vascular access, we need a plan for the maintenance of the vascular access. And our goal is to maintain the patients with a good access for a good hemodialysis longer time possible. The question of my presentation are two: clinical benefit from the use of DCB, and what about the cost benefit? Today, the DCB and Panos underline perfectly this problem. Are an attractive treatment with positive evidence, with some doubts, but the evidence of the doubts is very limited. So in Varese, I'm a vascular surgeon and I work in Varese. During the COVID pandemic, we perform a comparison, and for first time we have the evidence about the role of our closed follow-up and very aggressive maintenance with a DCB strategy for the treatment of intimal hyperplasia in our vascular access. So if you see the orange line is the line about 2020 compared to 2019. The clinical evaluation, the angiographic procedure stopped at the in Italy at the start of March, and naturally in our hospital, the number of thrombosis of the access and the number of central vein increase very rapidly after this type of stop. When a patient don't have the vascular access, naturally for first of all, the need continuous hemodialysis, the CVC and the line is probably the first emergent approach. This produces an incredible increase in the cost of maintenance. This other evidence is underlined in this terrible period of time. So after the 2020, our idea about the maintenance and the closed follow-up is very strong. And on the right or your screen, we see our flow chart for the follow-up and maintenance. The maintenance is based on the phlebography after a duplex ultrasound diagnosis. All the patients performing in a range of time from 1 month in very complex such to 6 months in the native without problem. So today we are in we perform a review of our practice with Aperto, and after 600 balloon and treatment of patients, we have some different evidence about this type of treatment with this balloon, and I share with you. The period of time of this study ranged from 2015 to 2023, a very close follow-up with a good follow-up index 0.86. The demographic data are very similar to all type of patients in hemodialysis in Europe. I underline 34% of diabetes. In our cohort of patients treated, 64% of this type of stenosis are de novo stenosis. 202 balloon for treatment of a native fistula, 293 for graft, and 105 for central vein stenosis. So in this retrospective analysis, we include all type of lesion. Surprisingly, 0.5% of patients underwent yearly only one treatment, 30% two treatment, and only the 8% of patients 3 or more retreatment for a year. So if I compare with my previous experience with the treatment of standard high pressure balloon, the period of time free from restenosis with DCB is very longer. So our faster we see the result of Aperto 600 in the native, the freedom from target lesion restenosis very well, more than 74%, 59% for graft. The stenosis in a graft have a more recoil compared a native stenosis, and 49 for central vein stenosis. Very important, the circuit patency, because this is our goal, maintain the patency with a good functionality for hemodialysis. So remember publicity of an ice cream in Italy, 2 is better than 1. We classify also the mean time for a new procedure after a DCB procedure, and surprisingly, the mean time for all the patients treated with Aperto DCB, the time for a new procedure is around, naturally, mean 233 days. And in the patients with the treatment of 2 or more stenosis, naturally, with 2 or more balloon, each DCB for only 1 stenosis, the period of time is more longer, 343 days of free from stenosis. I don't know the reason for this difference from 1 or 2, but probably when I treat all type of stenosis, the circuit patency is longer, and the number of thrombosis is reduced. Today we have a very good evidence, and I agree completely with Panos. Some different papers speaking about this is a randomized control trial with Aperto. My previous experience in 200 patients with Aperto, and this type of paper underline the strength of the DCB in the treatment of the new intimate hyperplasia stenosis. But the cost benefit, today we have another goal in our indication, choose the device with a positive cost benefit. With an economic university of Milan, we analyze our methods and our follow-up and type of maintenance. We analyze all type of costs, direct and indirectly, so the human resource, equipment, the treatment, the hospital bed, and more other costs. We perform two types of scenario. The first scenario, only the treatment of patients only with a PTA, and the second scenario, the PTA DCB. And naturally, starting the second scenario is not cheaper compared to first, but if we add the reintervention at the end of the analysis, at 1 year of the after the first DCB, the amount of the cost is very similar, but at 1 year, the cost effectiveness value, when I calculate the number of retreatment, the cost of all type of balloon, the scenario 2, the PTA with DCB is more effective, is more positive, the cost efficacy compared to first scenario. So the cheaper balloon is not effective in this type of treatment for our patients, and I'm very happy to speaking about also the different on naturally in the number of beds in the hospital for treatment is less in the second scenario with the DCB. And today we have also a benefit for the organization because the money spent for each patient is less, and also we calculate the CO2 spent for patients to come in the hospital, and naturally in the arm of DCB, more CO2 spend for coming in the hospital. So, in conclusion of my presentation, the literature underline a positive effect of the DCB in the treatment of the vascular access stenosis. The PTI DCB represent today the preferable option for reduce the number of treatment for year. We have a significant benefit from the patients, for surgeon, and for organization, and naturally for the health system utilize the DCB. And the last, for the environmental point of view, the reduction of CO2 spend for these patients is a good possibility for increase our quality of life. So thank you for your indication, and please, Robert from Hamburg, Germany, start with your presentation.
Thank you, Matteo. Thank you for this excellent presentation. And thank you for the kind introduction and invitation. I hope you can see my presentation now. Can you hear me, Matteo?
Yes, perfectly.
Perfect. Okay. Thank you. Yeah. So yeah, this title, From Theory to Practice in My Personal Algorithm, this is really difficult to find an algorithm in treating dialysis access, which kind of access we create and how we treat dialysis access. Here's my slide of my disclosures. And we've heard excellent presentations by the two previous speakers. And one thing that we know is that the dialysis access requires maintenance procedures more commonly than we actually wish for our patients. And in general, and also for me, the balloon angioplasty is the first-line option for treating stenosis in dialysis access. But we know that there are some disadvantages of balloon angioplasty, also such as the rupture of neointimal hyperplasia layer, which can increase the injury and also increase the damage, hence also increase the risk of more extensive neointimal hyperplasia and stenosis. Also, we know and we heard that the incidence of recurrence is high, especially within the 6 months. This is some kind of an endpoint for any kind of interventions, which is not a satisfying endpoint with 6 months. And we also heard and we also know that drug-coated balloons seem to increase the time from one intervention to another intervention. And we hope that maybe with increased numbers of types of the balloons, maybe in some kind of different anatomical locations, and like Dr. Kitru said, types of stenosis, which I also don't really manage to figure out which kind of stenosis this is. Maybe different balloons will play a different role. And we know that there are different types of balloons to treat a lesion using balloon angioplasty, several types of non-compliant, high pressure, ultra high pressure balloons, also scoring balloons, cutting balloons, and also there are different types of drug-coated balloons. And the APERTO balloon is a high pressure drug-coated balloon with its differences to treat dialysis access. As you can also read in a brochure of the balloon if you're interested in on their website. So it has the paclitaxel covered on it, and it is an anti-inflammatory and anti-proliferative effect. And actually, when I was thinking about using the APERTO balloon, I always try to figure out what novel device or procedure or technique we can apply to our patients to extend the life of their dialysis access, to reduce the reintervention rates without higher risks of those procedures. And then the costs, of course, come at the end, are also important. But then when I saw that there was evidence behind this balloon actually in dialysis access, this triggered my interest in trying the APERTO balloon also in my patients. And this is an RCT, and we already heard the experience of Dr. Tozzi with his extensive registry from Italy, now reaching 600 patients. So that was actually an interest of me to try the balloon. There was also an interest to see whether the balloon itself can change the outcomes of the patients based on the pressure, because we know that good vessel preparation is something that our dialysis accesses require prior to drug-coated balloon application, because the drug-coated balloon is not intended to treat the stenosis, but to extend the patency rate, the target lesion patency rate with the DCB, with its drug. But the question was also, which interested me, whether the APERTO balloon with its high pressure can be used as 2-in-1, basically using the high pressure of this balloon to crack the lesion, to completely extend the lesion, and simultaneously apply the drug. One of the reasons was also, like Dr. Kitru said, when we use a drug-coated balloon, we should extend the balloon longer than the angioplasty balloon we use for vessel preparation. Hence, we create probably, maybe, I'm not sure, more damage to the lesion or to the healthy vessel outside of it, because we see that the recurrent stenosis might be longer and heavier in the patients. So this was an interest of me to use one balloon as an angioplasty balloon, and I started using this balloon back in September last year. And I'm routinely using the DCB since a couple of years in over 80 to 90% of cases. And as of today, we have done it in 27 patients, and quarter of it were female patients, and most of the patients were using the dialysis access for either hemodialysis or apheresis, and the typical demographics such as 67 years old patients, in average from 36 to 88. So basically sporadically trying to figure out where to use it, and also in which kind of dialysis accesses to use and in which locations to use. So we have 2/3 of the patients who had previous interventions, and almost one third who didn't have any interventions. 37%, it should be not 27, sorry. And also we had patients with previous angioplasties reaching from 0 to 6. So 1.7 interventions previously. And as you can see, there are diverse types of dialysis access. We use it. So basically in every dialysis access we create here, starting from a snuff box and radiocephalic fistulas, also percutaneous AV fistulas and the surgical Gratz fistulas, proximal forearm, also arteriovenous grafts. And 63% of those lesions are actually juxtaanastomotic stenosis, which are known to be one of the main issues at forearm fistulas and also for endovascular AV fistulas. And we have also treated graft venous anastomotic stenosis in 15% of patients. And why is graft venous anastomotic stenosis interesting? Well, because we know that the stent grafts seem to gain more interest in treating graft venous anastomosis stenosis because of its significantly better patency rates rather than the angioplasty. So the thought was maybe we could avoid using stent grafts in those lesions if we can treat those lesions better with an angioplasty and a drug-coated balloon, hence the APERTO balloon. And the procedure success with 96%, why is it 96%? Because one patient had a significant recall after the intervention and we had to use stent to cover it. So that's why I decided to use it as a technically not successful angioplasty in this case regarding the balloon. And actually in 63% of those patients, we just used the APERTO balloon without a previous vessel preparation, whether it was an angioplasty or another device. So that was something interesting to see how APERTO performs as a standalone device, because I think that if it also proves to be efficient, at least as efficient, if not better, then we also spare costs on another device using prior to that. So when you look at this slide, of course, we have limited experience. We have mean of like almost half a year experience, ranging up to 252 or now already 253 days. And we have primary access circuit patency of 85% at 141 days. We have assisted circuit patency of 92.6%, and we have 96% of secondary patency rates for those accesses. And if you look into the last one, this is the freedom of target lesion patency reintervention. So it is 89% at almost 6 months. So it looks like the number of 89% at average 6 months is a good number, comparing it with the literature, with other experiences. And as Dr. Kitru mentioned about the publication on percutaneous AV fistulas and angioplasties, there are 5 of those patients that we treated with a APERTO balloon had a juxtaanastomotic stenosis in percutaneous AV fistula, in an ellipsis fistula. And as you can see, up to 252 days, all of them had 100% primary target lesion patency rate. Also, those 3 patients with graft venous anastomosis stenosis had also 100% of primary target lesion patency rates up to 154 days, so half a year. And only 3 of those 27 patients had a primary target lesion patency loss because one access was occluded and was abandoned due to another location, but still the access was lost. And there were 2 reinterventions at the same location at 72 and 238 days, which kind of shows that it looks like this balloon does very well. Now, I would like to show you a couple of cases. This one is a young patient. She's a female patient with end-stage kidney disease, and she had 3 different dialysis accesses already over 6 years, starting with a snuff box AV fistula and then proximalizing it to radiocephalic fistula. Eventually, when that vein was completely destroyed, there was a forearm radial artery to upper arm distal basilic vein straight AV graft placed, and this patient was referred with a graft venous anastomosis stenosis, which led to almost 300 flow. So it was a dysfunctional dialysis access. So this was the first time intervention at this lesion. There was a sonographic image showing this graft venous anastomosis stenosis. As you can see on the right side, the dialysis unit said she has 300 flow. We measured 565, as you can see on the left image. So it's a little bit different in dialysis access flow measurements. But on the right side, you can see this tight stenosis with 1.4 millimeter at the vein right across the graft venous anastomosis. So the idea was to treat it with only with an APERTO balloon without previous vessel preparation. You can see we used ultrasound guided technique. We wired the stenosis all across the over, used the balloon to do an angioplasty. This is an 8 millimeter APERTO balloon, which slowly inflated, and at 18 atmospheres reaches complete inflation, which we of course keep for 3 minutes and above. We do an extended prolonged angioplasty in general, but using DCB, of course, 3 minutes is our time. And then after the procedure, you can see clearly how the stenosis looks with an ultrasound, with color flow and also without it. And interestingly, this patient actually jumped from 500 to 2.3 liters flow. So we are monitoring her because this patient actually had a previous flow reduction procedure as a banding at the anastomosis. And because of some problems with dialysis, another surgical unit decided to remove that banding and created a patchplasty at that region where the banding was. So this treatment led again to an increase of flow. So we're going to reduce it if it stays high enough, but she's stable. So we're still monitoring her. It's a half year already. The second patient, also a patient with a graft. This is a male patient, slightly older, 51 years old. He had a previous brachial basilic fistula, and then it was converted very early to forearm AV graft loop, which was then replaced because the graft was completely destroyed in 22. There was an external surgery revision with patchplasty of both anastomosis, and then another revision of that patchplasties, so it was treated with a stent graft, and then simultaneously the outflow brachial vein was treated with an angioplasty, as for now 2 years ago. So then there was a patch infection. Somebody replaced partially the graft. So now the patient was referred with an outflow brachial vein stenosis and dysfunction. So this was his second intervention at the same location. And as you can see on the left image, the small one is the old graft, and the big one on the left side, the outer curvature, is the new graft. And on the right side, at the top, you can see the stenosis in the outflow vein. There was also some stenosis or some wall changes in the graft close to the stent graft at the graft venous anastomosis. So again, in this case, ultrasound guided procedure. Here's the stenosis in the outflow brachial vein on the left side. On the right side, this is the B-flow, which helps you to see the flow differences in the graft, where you have slightly but not completely echogenic changes in the graft wall. And then this is the 8 millimeter APERTO balloon, 8x40s, also no previous vessel preparation, single balloon inflation at 14 atmospheres. The balloon was completely inflated. Again, 3 minutes inflation time. We also used the balloon to dilate the changes in the graft. So you can see on the left side how the vein looked after the angioplasty. It reached almost 6 millimeter in diameter. And on the right side, that's the graft after the angioplasty. And the flow was increased to 1,400 cc's per minute. I think the example of the AV grafts is really interesting. Again, like I mentioned before, that the stent grafts seem to take over as primary, even in most cases, primary treatment of graft venous anastomosis stenosis by endovascular means. And this, of course, little group, small group, short experience, but this can also show that an angioplasty can be effective in treating graft venous anastomosis stenosis. And also, if you don't cover it and probably or possibly extend another lesion at the edge stenosis of a stent graft, you will have a new venous anastomotic location for another graft down the road in the future if the patients need another graft. So you will not completely cover the outflow vein over the time if you require it. Just to shortly show you this is a video. This is an outflow vein, basilic vein stenosis in a patient with a native fistula. And this, as you can see, there's the stenosis in the upper arm basilic vein, where we used ultrasound guidance to go over with a wire. So I think that in this case, it is interesting to see how this again 8x40 millimeters balloon behaves. Again, ultrasound guided procedure. This is the APERTO balloon covering the lesion, proximal and distal, and then we used to use slow inflation and also slow deflation to avoid recall and rupture. So this is this 8 millimeter balloon in this high-grade stenosis. This patient had almost functional occlusion of his graft or his AV fistula with a flow less than 200 milliliters per minute in the brachial artery. So in this case, the slow inflation over several, like 10, 15 seconds, 2 to 4 atmospheres. This is how I like to do it. And under the ultrasound, this gives you a visual example when the balloon completely inflates, how to deflate it. Is there a hematoma around it? Is there a recoil instantly around it, or maybe later on? And you can see that the balloon is already opening up and there is still some waste left at the middle, but still due to this balloon can reach up to 18 to 20 atmospheres. So you have the time to open up the lesion, like here you see, and then simultaneously apply the drug. This was 10 atmospheres and this lesion was already completely open. With that, I would like to thank the guys from Cardionovum for inviting me and for all the participants for being part of this webinar. Thank you.
Thank you, Robert, for your presentation. Thank you for sharing your case. I read some questions. The first for Panos. What do you mean when you say that the new MDR regulation is the biggest limitation for further investigation? Panos.
So yeah, it's a big problem for all the scientists in Europe, I believe, because the medical device regulation became so strict in the last 4 years that companies cannot actually test through studies new devices, and also even for the devices that we already used, they are asking for new studies, and this is becoming really expensive for the companies, to the extent that they decided to move or remove devices from Europe. And this is a big problem for our patients. This is what I mean.
Yes, Panos, I agree completely. So the second for me, yes, I finish our revision and probably our APERTO 600 cases will be published very, very soon. For altogether, according to your experience, is the DCB today the first line of treatment probably for the vascular access stenosis? What is your answer?
Robert?
Yes, well, looking into the problems with DCBs, we see that there is no survival issue anymore, mortality issue anymore. So this was one of the issues which pulled back a lot of users to use the DCB, and also looking into the tendency of most of the studies that the DCBs seem to be effective. I don't see any reason not to use the DCB as a first-line treatment and then wait until this lesion becomes so fibrotic that you may be even not able to apply the drug into the wall of the vessel. I remember we tend to treat the lesions in dialysis access with DCB if it was the second or the third one, but why should we wait until the second and the third one occurs? And that's why I'm using it in almost every case as a first intervention in our patients.
Thank you, Robert. Yes, I agree. Probably our goal today and for the future is to share or classify the lesion about the morphological aspect and perform the DCB only in the stenosis with the intimal hyperplasia, with the visualization of the intimal hyperplasia, not only the fibrotic area in the wall of the vein, because when we perform a lot of stenotic PTA, the wall is completely fibrotic. The DCB is not a magic device. Panos speaking about the cytotoxic effect of paclitaxel, the action is on the cell in replication. So it's necessary to have more cell replication in the wall. This probably is the key for our future and for an indication of the DCB in our future. Panos, what do you think?
I want to be a bit controversial. So I know the theory, and I've seen it in practice with the ultrasound, that there are different types of stenosis, and I agree, but there are hyperplastic ones and there are more others that are more fibrotic. However, we are not using the drug-coated balloons for the situation that exists at that moment, because the moment you do your vessel preparation and you do your balloon angioplasty, is you are destroying everything that was there. That means that it's like, it doesn't matter how a territory looks like after you hit a nuclear weapon there, everything is destroyed. So we are using the drug-coated balloons to slow down the process of restenosis, and the process of restenosis comes with new cells migrating into the lesion. So restenosis is a healing process of our body, and we are trying to stop it. So unless I have a study that can classify the lesions and prospectively see what is going on with the drug-coated balloons, I will still believe that there is no difference. Although I agree, because I've seen a question later on, that there are some studies that do not respond to drug-coated balloons as well.
Yes, you have completely reason. Probably in this overview, the paclitaxel is a prevention drug used for reduce the inflammation and the restenosis product by iatrogenic action of our balloon. So completely agree. Another question from the attendants: what's your recommendation if vessel recoil post DCB with predilatation? Would same size plain balloon be recommended or a size larger? Panos.
Yeah, okay. So first of all, I think that's the reason why we're doing predilation in most of the cases. So if you're not successful, there's no point using the drug-coated balloon. However, in the very few cases that you have a proper vessel preparation and you use your drug-coated balloon and afterwards you get a recoil, I would suggest the same size, because this recoil, if you have your vessel preparation and everything is working fine, that means that's a spasm. So either you give it a go and you wait for a couple of minutes and see what's going on, or you go for another balloon of the same diameter, probably the one you use for vessel prep. It's in our first studies with drug-coated balloons, when the sizes were very small, in most of the cases, because we didn't have the adequate sizes, we used the drug-coated balloons first, and then we used the higher diameters, like what we do in central veins. So we know that even if you post-dilate your drug-coated balloon, it will not be a problem regarding the effectiveness of the device.
Yes, yes, thanks, Panos. A lot of question this afternoon. So today is the correct time for have indication in guideline. With Panos, we speak a lot during the EVA meeting in Patras. It's a correct time to have indication on the use the DCB in our guideline. Robert, what do you think?
I think, yes, we should definitely recommend the DCB in the guidelines. And the question is that how we put it in the guideline, because there are studies which definitely, randomized control studies, which definitely show the advantage, such as the IMPACT trial. There are studies which don't show the advantage of DCB, the one from UK, and then there is the Lutonix trial, which shows it, but then it disappears after a while. That's why it is not as easy to very strongly put the DCB in the guidelines. But I know that there is work going on from the guideline committee with the companies to try to gather the individual patient-based data to be able to analyze the data, so that there is stronger information to use it for the guidelines as a recommendation. But in my personal opinion, and what the data shows is that there should be definitely recommendation in the guidelines.
Only my suggestion for you, Panos or Robert. Today we have some different randomized control trial about the DCB, but this paper is founded by the industry. This is a limitation for evidence, or this founding is not a problem about the evidence and the result. When the result is correct, when the randomized control trial is an high level of study.
I didn't exactly understand. So you mean whether we should use the drug-coated balloons or not? What was the question?
Yes, or if the evidence from a paper founding by the industry is a problem for the use of this type of evidence today.
No, I think if a study is properly performed and properly designed and is powered for the endpoint, it doesn't matter if it's done from it's an investigator-initiated study or a company-initiated study, because especially the company-initiated studies have the most rigorous control of what is going on. They are under MDR or they are under FDA. So and if you actually see all the big studies, because to make a randomized control trial, you need a lot of resources and money and millions. So most probably these studies are going to be done by companies, and it's fine as long as you can read and understand the results of the study every time.
Robert, from the audience, you have any morphological Doppler ultrasound criteria to select the patients fit for a DCB, and when you perform the DCB procedure under duplex ultrasound guide?
So I will answer the second one first. I almost exclusively use ultrasound for interventions, and it doesn't have anything to do with DCB only. The DCB is just an addition to the intervention. So we create a lot of distal accesses and a lot of AV fistulas. So most of our accesses are forearm fistulas. Hence, we have interventions in most of the cases, starting from the wrists, and the highest will be the proximal upper arm towards the axilla or cephalic, but not the cephalic arch, where we could use the ultrasound in almost every case to navigate to do the intervention. And occasionally, if there is difficulty to navigate through the stenosis, through the lesion, through the anastomosis, then we would use a C-arm to have another hand and eventually even an angiogram. If there is a central or cephalic arch stenosis, then I will not use an ultrasound because, first of all, it's a little bit inconvenient, and second of all, because of the curvature, tortuosity of a vessel, it is much more difficult to hold the probe in that proper position and be able to navigate. So most of the cases, ultrasound guidance. And then back to the first question, which kind of lesions? Again, it is really difficult to say which one will benefit from the DCB so far. So we see a lesion, there is a stenosis. Is it a valve? Is it a fibrotic tissue? Is it long? Is it short? Is it several after each other, like pearls? Like Panos said, when you do your vessel preparation, if you do it with a high pressure balloon, then you destroy anything anyhow. So the drug will be eventually preventive for the further neointimal hyperplasia by new cells. What kind of cells are going to be built there? Nobody can say. I mean, we're not doing a histological analysis of every lesion to see what kind of it and then trying to apply a DCB. So that's why, for me, the morphological image of a stenosis doesn't really matter to treat it with DCB.
Thank you, Robert. It's incredible. We don't have more time to answer other question, but I read and I respond by mail. So Diego, I think for you, the conclusion of our webinar, participant, more than 75 participant, a lot of question, high level discussion. I'm very happy to
You're right, Matteo. I'm very happy too to have such kind of participation from the audience. I would like to thank one more time the speaker, Dr. Kitru, Professor Tozzi, and Dr. Shaverdian. It will be an amazing session. Really, really thanks for your expertise. You enrich a lot the topics, and I think you gave us a really well and clear vision of the future and the actual and the future of DCB. Last things, I would like to thanks also to all the participants to this session, but also to be so active during the sessions. So in name of Cordionovum, thanks a lot, and thanks to also for the speaker to reply in a separate way. I'm seeing you are replying manually to the missed questions. Thanks again. Have a great evening, and I hope to have the opportunity to repeat such kind of experience with such great panels and such great audience. Thank you to everyone. Have a nice evening, and we'll be in contact soon.
Thank you, Diego.
Bye-bye.
Bye.
Thank you.
Bye. Bye-bye.